Before that, we will take the life cycle of Entamoeba histolytica. Here, this organism, you can see that here this is an intestinal lumen, and in the lumen, the trophozoite stage is getting converted into a cystic stage. Okay, trophozoite stage enters into a cystic stage, and this trophozoite moves out of the lumen of the intestine and affects the bloodstream, therefore moving towards the liver and causing liver abscess. So a lot of alcoholic patients, they come to the hospital with liver abscess. Liver, due to alcohol, is already not working well, and then there is superimposition of this kind of protozoal infection leading to liver abscess. And another thing is that it can result into intestinal ulcer formation. So what you have to remember is that intestinal lumen, there the organism has got two stages. One is the cystic stage, which passes through the feces, and another is the trophozoite stage, which passes across the intestinal lumen, comes in the blood, and then infects the liver. So these are the two variants which you need to handle as far as the Entamoeba histolytica organism is concerned. So what do you see in the tissue amoebocyte? That is metronidazole, which is given. It is the most commonly used drug. Mixed tissue amoebocyte, and affecting both the intestinal as well as extraintestinal area. Not reliable, effective against amoeba in lumen, as luminal concentrations are too low for a single drug treatment. So metronidazole is very commonly used, and it is only going to kill the trophozoite phase, that is the T phase. It is not going to kill the cyst phase. Okay? So if you are prescribing metronidazole, make sure that it is going to kill only the intestinal wall, that is the tissue phase, not the cyst phase, not in the lumen. Lumen mein you have only a single drug, that is here. That cyst is there, which is passing through the feces, and then you have trophozoite, which is crossing the intestinal lumen and then entering the blood stream. So metronidazole very commonly you will be facing whenever you are going to the clinical postings, and it is a very, very good drug. Once a clinician gives this drug, he is very much satisfied that the patient protozoal infection will be treated. So chemically this is a nitroimidazole. Absorption is well and almost complete from the GIT. Some unabsorbed drug reaches the colon. Then distribution, there is a rapid and wide, distributed in all the tissues with high concentration in body fluids as well as CSF and brain. Now this is important कि अगर किसी को pneumocystis carinii या कोई भी protozoal infection है, it reaches the CNS, and CNS में infection होगा, then you have to give metronidazole so as to clear it out. Okay, so the thing is that protozoal infections, they reach up to the neurological system. They affect the cerebral nervous system, and also they can also be seen in the vaginal area. So you have certain metronidazole creams also which comes to treat that infection. Then metabolism occurs in liver that may accumulate in hepatic insufficiency, and excretion is through urine, and the preparation you can have in all oral, IV, topical gels and cream. So this is something on metronidazole pharmacokinetics. Then the mechanism of action, metronidazole kills the protozoa, and also it is bactericidal for anaerobic bacteria. So it is a prodrug. This is important that besides protozoa, it is going to affect the anaerobic bacteria which are present in the gut, as well as other pathogenic anaerobes. It requires reductive activation of the nitro group. This occurs in sensitive aerobic protozoa and anaerobic bacteria by ferredoxins. So these ferredoxins are basically electron transport protein acceptors. Okay, and these proteins, they can donate electrons to metronidazole, which serves as electron acceptor. The reduced product is a cytotoxic substance that is going to target the DNA and is going to kill the protozoa. So basically, this is the mechanism how it is going to function. You have a pyruvate ferredoxin oxidoreductase enzyme pathway, that is PFOR pathway over here. Metronidazole, which is given, it is going to enter the protozoal cell, and then it is going to affect this pathway, which is marked through red, that is pyruvate ferredoxin oxidoreductase enzyme pathway. The electron transport chains, जो electrons होते हैं, that will be accepted by metronidazole, and hence there will be changes in the molecular level, DNA level of the organism, and so the organism will die. So you should remember that there is something called as PFOR pathway for the mechanism of action of metronidazole. Resistance, it's not a therapeutic problem as of today. There are certain strains of Trichomonas vaginalis that are becoming resistant. What organism does metronidazole drug covers? It covers Entamoeba histolytica, trophozoites only, not the cystic phase. Then Trichomonas vaginalis, then Giardia lamblia, Clostridia, that is Clostridium difficile, Clostridium perfringens, then Bacillus fragilis, Helicobacter pylori, and Campylobacter. So these were the antimicrobial coverages. It is very difficult to identify the organism sometimes, and then it becomes a problem, because your antibiotic therapy will not be guided towards the organism, and unfortunately organism multiplies exponentially. Organism कभी भी 1 से 2, 2 के बाद 3, 3 के बाद 4 इस तरह से नहीं ग्रो करता. ऑर्गेनिज्म मल्टीप्लाई करता है एक्सपोनेंशियली, 1 से 2, 2 के बाद 4, 4 के बाद वो सीधे 16 होगा. It will go exponentially. So whenever antibiotic therapy is delayed, the patient will lose a lot of time in his recovery. इसलिए कल्चर रिपोर्ट करानी जरूरी है, ऑर्गेनिज्म आइडेंटिफाई करना जरूरी है, टारगेटेड थेरेपी देना जरूरी है. इफ यू मिस ऑन टाइम, you will miss on life. This is for sure with the microorganisms, because they don't multiply like 1, 2, 3, 4. They multiply exponentially. Okay, so this you have to remember. So you have MABSs, one disease, drug of choice in all the tissue infections. For what? That is the metronidazole. This is all the drug therapy of metronidazole. One is MOBSs, where metronidazole acts as a drug of choice for the hepatic MABSs, for acute intestinal MABSs. Okay. Then there is trichomoniasis. Again, the treatment of choice is metronidazole. Then giardiasis. Basically, जो organism का नाम है, अमीबा है तो MOBSs हो गया, और trichomonias है, that is the organism, तो उसका जो disease है, that is trichomoniasis. And Giardia is the organism, so the disease is Giardiasis. Treatment remains the same, that is metronidazole. And then you have already read this eradication of H. pylori in peptic ulcer. Peptic ulcer में 3 ड्रग का कॉम्बिनेशन होता है, where one is metronidazole, another is clarithromycin, and there is a third component which is a proton pump inhibitor. So this you have already read earlier. Then there is a pseudomembranous enterocolitis caused by Clostridium difficile. Another is anaerobic intra-abdominal infection and brain abscess. So there is even component of prophylaxis, especially for colorectal surgeries. So when you talk of antimicrobial, they have got varied role. One is in prophylaxis. जब आपको पता है कि हम गट की सर्जरी कर रहे हैं, स्प्लीन की या किडनी की या लिवर की, गट मीन्स दैट इज योर लिवर, इंटेस्टाइन, स्टमक, अगर उनकी सर्जरी कर रहे हैं, या फिर आप जेनिटोयूरिनरी ट्रैक्ट में सर्जरी कर रहे हैं, तो प्रोफाइलेक्टिकली यू गिव मेट्रोनिडाजोल, क्योंकि यू कांट एक्सपेक्ट फर्स्ट ऑर्गेनिज्म टू कम इन इन्फेक्ट एंड देन वी प्रेस्क्राइब द मेडिसिन. सर्जरी इज अ बिग थिंग. इफ सर्जरी इट मे गो इन वेन, पूरी सर्जरी आपकी खत्म हो सकती है इफ द पर्सन कैचेस इन्फेक्शन, दैट इज फॉर श्योर. हॉस्पिटल की यूनिट्स बंद हो जाती हैं अगर इन्फेक्शन फैल जाता है तो. इफ देयर इज अ इन्फेक्शन एक्सप्लोरिंग इन पीडियाट्रिक आईसीयू, पूरा का पूरा आईसीयू शट डाउन करना पड़ जाता है. देयर इज नो अदर एस्केप इनटू इट. व्हेन यू टॉक ऑफ माइक्रो ऑर्गेनिज्म यू हैव टू कंट्रोल देम, क्योंकि आप अच्छा काम करोगे उसके बाद ऑर्गेनिज्म पेशेंट को ले जाएगा, दैट इज नॉट एक्सेप्टेबल neither to the attendant nor to the doctor. So then you have to shut down the ICU or the hospital until unless you recoup with the clean and the safe environment. So you have a bacterial vaginosis, that is another area where metronidazole is used, and then you have something like acute necrotizing ulcerative gingivitis, very rarely seen, but yes, it's a good area where metronidazole can be given. Then you have adverse effects in the GIT, that is dry mouth and metallic taste. Most of you might have experienced some kind of food poisoning across your life till this age. जब भी food poisoning होगी, you take Norflox TZ, Ciplox TZ, that is ciprofloxacin and tinidazole. Norflox TZ is again norfloxacin and tinidazole. So that is what we are talking today of tinidazole, metronidazole, sacnidazole. Okay. So when you take this kind of a drug, you have a dry mouth and you have a metallic taste. आपका टेस्ट चेंज हो जाता है and then you feel like कि अभी भूख नहीं है, अभी कुछ खाना नहीं है. So this happens in the case of food poisoning, because that is the food is poisoning may occur as we have seen in the earlier slides. So you have another GIT side effect, that is nausea, vomiting, abdominal cramp, diarrhea and oral thrush, that is stomatitis. Then you have neurotoxicity, which is headache, insomnia, numbness, paresthesia and peripheral neuropathy. Then thrombophlebitis, that is in the injected vein. Other adverse events, disulfiram-like action with alcohol. ये आप already पढ़ चुके हो in the CNS when alcohol was taught. There is a disulfiram-like action with alcohol. Dysuria and dark urine. Then hypersensitivity reaction, rashes, urticaria and itching. Then you have certain drug interactions with metronidazole. Increased anticoagulant effect of warfarin. So warfarin कब दी जाती है? As an oral anticoagulant. किन cases में देंगे? Whenever there is patient of pardon? Okay, disseminated intravascular coagulation. Okay. And there are multiple areas. For example, जब भी आपको valvular surgeries करनी है, rheumatic heart disease के patient हैं, valvular surgeries करनी है, so these people they run on warfarin. Warfarin चलता रहेगा, तो उसके बाद में food poisoning तो हो ही सकती है ना. If the person is running on warfarin, taking it daily, and now he has a good atmosphere outside and goes for pani patashi and eats it, and then falls into some kind of infection, then you give him metronidazole, then what will happen? It will end up into interaction. So it is going to increase the anticoagulant effect. So all the things are interlinked. Once you are having a person who is regularly taking medicines, then that becomes a point of concern to be looked into for drug interactions. Because you are giving something for short period of time, but then it will alter the another pathophysiology of the patient. Another drugs you have phenytoin, phenobarbital. जब phenytoin you give it for seizures, तो seizures वाला patient है, हो सकता है 6 महीने से उसको phenytoin की low dose चल रही हो, and then you prescribe metronidazole. So what is the catch? Catch is that whenever you are examining a patient, taking history of the patient, ask for any kind of already drugs he is taking, any kind of already disease he is suffering from. If you miss on that, you may do harm to the patient. Then you have metronidazole increasing the lithium toxicity by decreasing the renal elimination. So what is there in the contraindication? The patient with active diseases of the CNS, hepatic diseases, renal diseases, dose adjustment should be done, pregnancy and nursing mothers. So when you look at the patient profile, you will have all kind of stuff coming in with pediatric to adult to elder, then specifically with comorbidities like diabetes, hypertension, CKD, that is kidney diseases patient, and even certain neurological ones. So whenever you are prescribing, you have to enter into the history or the already drug treatment the patient is taking in. Otherwise, you may benefit for your area of concern with which the patient has come to you, but you will harm the other continuous treatment which he was taking. Another congener is the tinidazole, that is similar to metronidazole in spectrum of activity, mechanism of action, absorption and adverse effect. It is longer acting, once a daily dose, and short course 2 gram daily, single dose for 3 days. Secnidazole, longer acting, single 2 gram dose is given. Then comes your amytines, that is another group of antimicrobial therapy. So the source is alkaloid ipecacuanha, then dihydroamytine, that is the synthetic analog, and effective against the trophozoites of Entamoeba histolytica. Here you have certain therapeutic uses. It is limited to only when metronidazole cannot be used. तो कुछ एक केसेस जिसमें metronidazole के अगेंस्ट एलर्जी हो, देयर यू हैव टू फाइंड अ ऑप्शन कि इसके metronidazole से तो एलर्जी है, तो हमें क्या देना है, then we can give this kind of a treatment. Okay. And what is the therapeutic use? It is severe amoebic dysentery, hepatic amoebiasis. Dihydroamytine is preferred as compared to amytine because it is having less toxic profile. Drug should be used subcutaneously or eye injection in a supervised setting and used only for minimal period to relieve the severe symptoms, usually given for 3 to 5 days. In clinical practice, we don't use this amytine drugs. They are only reserved whenever there is allergic reaction to the primary drug, that is metronidazole. So what are the adverse effects? They are diarrhea, nausea, vomiting, pain, tenderness at site of injection, and sterile abscesses, then muscle weakness and discomfort, and minor ECG changes. So you have a serious toxicity profile with hypotension, cardiac arrhythmias, and cardiac failure, and contraindication cardiac renal diseases, young children, and pregnancy. Another drug is chloroquine, which we often give for malaria. So it's an anti-malarial drug, tissue amoebicide, especially against Entamoeba histolytica, amoebic hepatitis, and liver abscesses. It is concentrated in liver, so it kills the trophozoites of Entamoeba histolytica. Not effective for amoebic colitis or luminal amoebae because absorbed in upper intestine. So it's basically uses in hepatic amoebiasis, abscess, not responding to metronidazole. So if you have an alcoholic patient, he may come to you with pain on right side of abdomen. When you go for USG, then you see that there is an abscess in the liver. Now once abscess is there, it depends upon the size of the abscess कि जो आप एंटीबायोटिक दे रहे हो वो एक्ट भी करेगी या नहीं, क्योंकि जहां पे एब्सेस बन जाता है वहां पे एसिडिक एनवायरनमेंट क्रिएट हो जाता है एंड देन द एंटीबायोटिक्स में फेल. ओके, सो वंस अगेन एंटीबायोटिक्स देनी तो पड़ेगी सो दैट अदर एरियाज डोंट गेट इन्वॉल्व इन दैट एब्सेस. ओके, बट दैट डजंट मीन कि आप एंटीबायोटिक देके एब्सेस को ठीक कर सकते हो. अगर एब्सेस छोटा होगा तो ठीक हो जाएगा, अगर बड़ा होगा तो उसमें आपको ड्रेन करना पड़ेगा. ओके. Then another drug which is acting in the lumen, that is the diloxanide furoate, that is pharmacokinetics में given orally in gut, it splits into the diloxanide and furoic acid. 90% diloxanide is absorbed and conjugated to form glucuronide excreted in urine. Mechanism of action is actually not known. Unabsorbed diloxanide is directly amoebicidal and against amoeba in lumen, but not those in the intestinal wall. So very less it is used. काम की दवाई सिर्फ metronidazole है और अगर वो फेल होती है तो फिर डाइहाइड्रो amytine, and these kind of drugs are used. Therapeutic uses, the drug of choice for asymptomatic luminal amoebiasis, that is cyst passers. Then you have, along with the tissue amoebicide in severe intestinal and extra-intestinal amoebiasis. So those people who handle the food, जैसे कि होटल इंडस्ट्री है, उसमें जितने भी शेफ्स होते हैं, उन सबके इसके लिए टेस्ट होते हैं that they are not carrying the cyst of this kind of protozoa. Otherwise, it will multiply and it will pass on to the customers who are eating the food prepared by them. So you have then adverse effects, that is flatulence, nausea, abdominal cramps, skin rashes, which are seen rarely, and precaution is in pregnant ladies. Another is iodoquinolone. That is a halogenated hydroxyquinoline and an effective luminal amoebicide used with metronidazole to treat the amoebic infection. Only effective against trophozoites in lumen. Then pharmacokinetics, 90% it is unabsorbed and 10% it is absorbed, excreted in urine with half-life of 11 to 14 hours. With the adverse effects of diarrhea, anorexia, nausea, vomiting, pain, abdomen, headache, dermatitis, urticaria, pruritus, fever, increase in protein-bound iodine, that is decreased iodine 131 measurement. So these all things are actually not of much use, they are having only theoretical use. Clinically जब आप देखते हैं तो metronidazole सबसे काम की दवाई है, उसको देने के बाद there is not much of the use of other medicine until and unless specifically the organism is asking that this is giardiasis, this is this trichomoniasis, so then you have to give a specific drug. Then cautions में it is taken with meals, with caution in optic neuropathy, then non-amoebic hepatic disease and renal and thyroid diseases. Contraindicated in intolerance to iodine. Coming to the antibiotic, that is paromomycin, tetracycline, these are the two gross antibiotics which are given, and it is used in asymptomatic infection along with extranumeral amoebicides in serious infections. The role is very less. Then paromomycin sulfate, aminoglycoside antibiotic, not significantly absorbed from the gut, used as luminal amoebicide, less toxic than other agent, superior to diloxanide furoate in clearing symptomatic infection, asymptomatic infections, no effect on extraintestinal amoebic infections, also used in visceral leishmaniasis parenterally, and adverse events are abdominal distress and diarrhea. Another, the tetracycline used as luminal amoebicide, does not kill bacteria directly but disturbs the symbiosis between normal intestinal flora and amoebic Entamoeba histolytica. So there are certain drugs which are going to affect your gut microorganism. अगर gut microorganism affect होंगे, then the side effects will be coming. Like there may be diarrhea, there may be constipation. This is because the gut microbes have been disturbed, and so the routine जो frequency of bowel है, that will change. And tetracycline, which is a broad spectrum antibiotic, will kill these flora, leading to the death of Entamoeba histolytica also. Then treatment of different diseases, different disease forms of amoebiasis. This is from clinical orientation, that if there is asymptomatic intestinal infection, generally you don't treat in endemic areas. In non-endemic areas, treated with luminal amoebicide. So when you talk of endemic and non-endemic, refers to, for example, a patient comes to you from village setting. He is a farmer. So he comes to you with kind of a abscess. So you expect, since he has been working with mud, so there is a huge chance of getting protozoal infection. But suppose you have a patient who is a IT software person who deals with computer and sits in AC. So usme there is no point of giving this kind of antibiotic until unless he says that he has taken some kind of a food outside that may be the cause of source of infection. So you have to see the patient, you have to see what kind of workaround he is performing, and then give the antibiotic therapy. In non-endemic areas, treated with luminal amoebicide, that is diloxanide then iodoquinol and paramomycin. So it may be combined with tetracycline. Then there is amoebic colitis with dysentery. Mild to moderate intestinal infection, you have drug of choice, that is metronidazole and a luminal agent. Another severe intestinal infection, once again metronidazole and luminal agent, these become the drug of choice. Hepatic abscess, amoebema and other extraintestinal infection, once again the drug of choice is metronidazole and a luminal agent. So different kind of microorganisms जो अभी आपने देखे, उन सब के लिए अलग अलग treatment profile है, that the microbiology department will tell you that this is the organism and then specific therapy you are going to give for that organism. That is like giardiasis है, so you can give either of them. Leishmaniasis है, you can give either of them. So it is broadly you give metronidazole. Finally, once the culture report comes, then you give your directed therapy. Another topic for the day is leishmaniasis, a disease that is caused by intracellular protozoa parasite transmitted by a bite of female phlebotomine sand fly. Clinical spectrum ranges from self-resolving cutaneous ulcer to a mutilating mucocutaneous disease and even to a lethal systemic illness. Quite prevalent in these areas like Bihar, West Bengal and Jharkhand. So, leishmaniasis is not prevalent in Rajasthan. It is an endemic disease seen in these three areas. Okay. This is the kind of skin picture that you get when there is leishmaniasis. So what is the life cycle? You have a sandfly and you have a mammal. So in the sandfly, it is a promastigoid stage, while in mammal it is the amastigoid stage. Okay. These are the drugs which are given: sodium stibogluconate, amphotericin B, miltefosine and parmomycin. The sodium stibogluconate is actually obsolete in India. It is no longer used. Amphotericin B is an important drug which is available and which is given also. It is the first line drug as per WHO. Second line drug, silence. It is first line drug in WHO and second line drug in National Vector-Borne Disease Control Program. So the drug of choice in pregnant and lactating women. Then most effective drug while treating leishmaniasis is amphotericin B, and it appears in two forms. One is the amphotericin B deoxycholate and another is liposomal form. The liposomal form of the drug is very effective and it is the drug of choice in pregnant women as well as breastfeeding mothers. Then there is miltefosine. It is again the first line of drug in National Vector-Borne Disease Control Program, first orally active drug. Mechanism of action is not clear. ADRs, that is adverse drug reactions, anorexia, vomiting, diarrhea, allergic reaction, and it is quite teratogenic. Dose, a 4-week course attains 95% cure rate in India. Then paramomycin, topically effective in dermal leishmaniasis, less effective as compared to the amphotericin B, and adverse event is ototoxicity. Combination therapy is also given, but the cost of liposomal amphotericin B is quite high. If there is a patient with HIV and leishmania co-infection, it is going to worsen each other. Co-infected patient, they will have poor response to both the treatment and mortality is high. Drug used locally for dermal leishmaniasis, that is paramomycin and the antibiotic if there is a secondary infection. This is the recommended drug with dose which is given in leishmania diseases. Okay. So you have amphotericin B and you have in that liposomal as well as the another, that is deoxycholate forms. then you have miltefosine, then you have paramomycin. So this all is available, and you can go through them, the drug dose and the duration. Now coming to the last two things, that is the National Health Program, Intensified Diarrheal Control Program fortnightly. When you look grossly, as India, major population resides in the villages. So at that level, the government has started this IDCF, that is Intensified Diarrhea Control Fortnight Program, to increase the awareness on usage of ORS and zinc in diarrhea. And the target is zero child death. Since 2014 this program is running, and during the fortnight, that is during the period of 14 days, they are targeting the under 5 years of age children, because the village children, they play in the mud, they grow over there, and even they play with the cow dung cakes. So therefore they are much and much prone for diarrheal infections, and henceforth, to curb the diarrhea, this under 5-year age group has been targeted by the national program. And they communicate through mass media, through local media, through Anganwadi preschools, and they established ORS and zinc corners so as to give information, education, and as well as free distribution of ORS. So the key message of the fortnight is giving zinc for 14 days for children suffering from diarrhea, even if diarrhea stops. So this is something about the Intensified Diarrhea Control Fortnight Program started by the Government of India. And then you have National Kala Azar Elimination Program, with the objective of the program to reduce annual Kala Azar case incidence to less than 1 case per 10,000 population at block level by the end of 2023. And the elimination strategy, there is Government of India adopted these following strategies. Early diagnosis is important, then integrated vector management and vector surveillance, and supervision, monitoring, surveillance and evaluation, strengthening capacity of human resource in health, advocacy, communication, social mobilization, and program management. So government functions at its own level to eliminate the disease from the endemic areas. So here we end for the day.